Developmental defects on the basis of number. There are supernumerary tooth, oligodontia, and anodontia. In supernumerary tooth, mesiodense is most common than the fourth molar. The types of supernumerary tooth are conical, which is most common shape, then tuberculate, having more than one cusp, then supplemental, and odontoma associated. The syndromes associated with supernumerary tooth are Gardner syndrome, which has cleft lip and palate also, then credocranial dysplasia, and Ehlers-Danlos syndrome or Rubberman syndrome. In oligodontia, there is less than 6 teeth, and the syndrome associated is ectodermal dysplasia, where the skin, eye, teeth, hair, nail, and sweat glands all are affected. Now, on the basis of size, macrodontia and microdontia. Macrodontia is seen in pituitary gigantism, microdontia in pituitary dwarfism. In microdontia, third molar is more common than the maxillary laterals. It can be associated with Down syndrome. In Down syndrome, the other features which could be seen are brachycephaly, class 3 malocclusion, anterior open bite, fissured tongue, low caries incidence, and high incidence of periodontal diseases. On the basis of shape, there is fusion and gemination. Both occurs before the calcification. Fusion is occurring at the dentinal level, and gemination is an attempt to fuse incompletely. Then concrescence, which is occurring at the level of root at the cementum. Then taurodontism, which is also known as bull's tooth. There is increase in the coronal part at expense of root. The syndromes associated are Klinefelter syndrome and ectodermal dysplasia. The types are hypo, meso, and hyper. In hypotaurodontism, there is a slight increase, and then hyper, there is extreme increase in the coronal part. In Klinefelter syndrome, the other features are, it is a syndrome of XXY, there is large crown, prognathism of jaw, and the males are taller with long legs, and the puberty is delayed. Now dens in dente, that is tooth in tooth. First is coronal and second is radicular. In coronal, there are 3 variants. First is invagination till the crown, second till the crown CEJ, and third is perforation beyond CEJ. Then Lyon's premolar or dens e vaginatus. It is an outgrowth of enamel, where enamel pearls are also seen. In the bifurcation of molars, it is a type of hamartoma. Dilaceration is bent in root. Talus cusp, also known as eagle's claw. It is an extra cusp on the maxillary laterals. There is overgrowth of cingulum. The syndromes associated are Rubinstein-Tabby syndrome, having short stature also, then Mohr syndrome, having oropharyngeal digital syndrome of type 2, then Sturge-Weber syndrome. Next is amelogenesis imperfecta, which is X-linked recessive disorder. There are genes affected which are enam in enamelin, then amyl X, which is amylenin protein or amelogenin, then MMP20 or enamelizin. It is a purely ectodermal disorder. Also DLX3 gene is also affected. DLX3, enam, MLX, MMP20. 4 classifications. First is hypoplastic, where there is defect in the matrix, that is, it is a quantity defect. The shape of crown is normal but enamel is soft. Second is hypocalcified, there is no calcification of the matrix and the dentine is more radiopaque than the enamel. Then hypomineralized, where there is a similar radio opacity of both enamel and dentine. Fourth is the combination of all the above. Then dentinogenesis imperfecta, there is defective bone formation. It is autosomal dominant disorder. The tooth is hereditary opalescent tooth and Cape de Pons tooth. Two terms used for the tooth: hereditary opalescent and Cape de Pons tooth. There is defect in the chromosome 4, which forms the dentine cyalophosphoprotein DSPP. We see extensive occlusion and incisal wear. On radiograph, we see extensive deposits of secondary dentine. There is Shields classification in the dentinogenesis imperfecta, type 1 and type 2. Type 1 is the opalescent type. It is tulip shaped. Type 2 is Brandywine type of tooth. In type 1, there is large coronal part and very small root and thin pulp chamber and root canal. It is known as tulip tooth. Whereas in type 2, it is known as shell tooth or Brandywine tooth, having a large pulp chamber and thick root canal, which appears like a shell and therefore the name. And the dentine and enamel are very thin. There is loss of scalloping at the DEJ. This loss of scalloping at DEJ is also seen in scleroderma and Ehlers-Danlos syndrome. Now, dentine dysplasia is also having two types, type 1 and type 2. Type 1 is radicular and type 2 is coronal. In the type 1, there is extremely short roots, also known as dwarfed roots. In the primary dentition, pulp is not formed in both the types, and in permanent dentition, there is very thin pulp, crescent shaped, with osteodentine formation in type 1, that is radicular type, and in type 2, coronal type. In permanent dentition, the pulp is large, giving it thistle tube appearance, which is a characteristic appearance of type 2 or coronal dentine dysplasia. In type 1, histopath shows lava flowing around the boulders. Next is regional odontodysplasia or odontogenesis imperfecta or odontogenic dysplasia, where both enamel and dentine are affected. They are very thin, having a large pulp area. Its etiology is latent virus found in the odontogenic epithelium. Histopathology reveals wide predentine zone and large areas of interglobular dentine. And there is ghost tooth appearance.